Hi, everybody. This is Sage Lewis. Today I'm your host, and I'm talking with Dr. Stanfield. How are you today, Doctor?
I'm doing great. Thanks, Sage.
Good, good, good. So today I thought we could talk a little bit about robotics and your profession.
Okay, great. Yeah, robotics has been relatively new to the orthopedic world, particularly as it applies to joint replacement. And so for the last several years now, I've been doing robotic hip and knee replacements. And it really has added a level of accuracy and really improved our efficiencies when it comes to joint replacement.
So this is interesting to me. As a person who knows almost nothing about this, like how important is microscopic detail in this work?
Sure. Great question. So, knee replacement, for example, is more of a resurfacing where the ends of the worn out bones are removed and replaced with metal and plastic. And so the sizing of that metal and plastic and the positioning of that metal and plastic is extremely important. And small variations can make big differences. And so with the robotic system that we're using now, we do a CAT scan before the surgery and a 3D reconstruction. And so in the virtual world, we can actually size the knee replacement that we intend to insert, and we can decide exactly the position we want to insert that replacement. And then that's locked into the robotics. And essentially, it's a high-tech GPS system that allows us to recreate in the operating room what we did in the virtual world.
So when I was a kid, I got a retainer, and I remember like they put this goo in my mouth and they created basically a cast of my mouth with this goo, you know. Is this what you're doing with with these scans? You're creating a 3D image of that place and replacement part?
Sure, that's one way to look at it. Where we do a high sensitivity CAT scan, and we have the technology to convert that CAT scan, which is a two-dimensional image, into a three-dimensional image of the arthritic knee. And then from that, we can remove the amount of bone that we want to remove and replace that with metal and plastic, which is what we're going to do at the time of surgery with the knee replacement.
Okay, so are the parts custom to the patient, or are they kind of off the shelf parts, I
Sure,
guess?
that's a good question. There are custom implants available. Of course, there's an extremely high cost to be able to do individualized implant for every patient. So with this robotic system that we're using now, we have off the shelf sizes. We have multiple sizes, over 10 femurs and over 10 tibias, and then different size plastics. So there's a limitless, essentially, supply of different sizes and implants that we're able to use. But the benefit is not so much in a custom implant, but in customizing the implantation, if that makes any sense. So
Yeah.
we're individualizing and predetermining the sizes we're going to implant and where we're going to implant them, and then able to reproduce that with extreme accuracy at the time of surgery.
So are you almost like customizing the bone a little bit?
Yeah, we're customizing the technique. So
Okay.
to say it in a different way, let's flip back to traditional, we'll call it knee replacement. And what that uses is jigs and guides that are based on that patient's anatomy and averages as far as the all comers for joint replacement. And so those implants are put in and sized and positioned based on where most people would end up. And as with any technique, there's a bell curve. So most of those are going to be just fine, but there are some outliers that it's just not going to feel right or not be just fine. And so this allows for that because we're putting it in where that particular patient's knee and that particular patient's anatomy says that it should be placed.
Okay, I think I'm getting it. So so before robotics, there was like, well, there's a bell curve. Most of you are going to be pretty great. A few of you, maybe not. But now with the robotic stuff, you're saying I can make this very precise to your specific needs.
That's very correct. Yes.
Okay. So when the surgery happens, is it you and a robot on the doing the surgery?
Yeah, essentially, yes. It's a robotic arm that I used at the time of surgery. So there's a very rigorous calibration that takes place at the time of surgery to assure accuracy. But once we go through that calibration, then all of the cuts are made without any jigs or guide, just with a robotic arm and me controlling that arm while I watch a video screen and the knee at the same time. So it's done without any specific cutting guides or alignment tools. It's all done with the robotic assistance.
Wow. But you're controlling it, or is it doing it based on the
Correct.
scans?
So specifically, the way that it works is I line the saw up within a field that the robot recognizes. Then I squeeze the trigger on the saw and it corrects my specific alignment and angulation. And then once I get it where in the alignment that it needs, I squeeze the trigger again and the saw starts cutting. And the robot also stops me from going out, essentially coloring out of the lines. It keeps me in that field so that there are no, we don't remove too much bone or too little bone. It's right on target within 0.1 millimeter.
Wow. That's incredible. So I guess that's the interesting part. Well, I mean, it's all interesting, but really we're trying to kind of structure the bone so it's going to fit that part perfectly. Is that right?
Correct. And the reason, so I'm not here to say that traditional knee replacement isn't a great operation, because it really is a success rate it's unprecedented, greater than 95% success rate with traditional knee replacement. And so it's hard to argue with that. The robotic assisted joint replacement allows for us individualizing where we're going to position that implant and size it. And therefore, in the short term, it feels more normal because it's in that specific patient's anatomical region where it's supposed to be in alignment. And in the long term, if we can avoid any outliers as far as position and sizing, then the success of that implant should last longer than traditional joint replacement.
Wow. So it's going to be more comfortable right out of the gate and potentially could last longer.
Correct.
Are you doing all your replacements now robotically?
I would say 90% of the hip and knee replacements that I do are done robotic now. There are some patients who have, for example, if they have hardware in their knee, or it's a redo joint replacement, or they've had plates and screws from some other procedure, they're not candidates for this because of the CAT scan has to be high quality, and you get scatter with other metal artifacts that are in the joint replacement. But other patients who would prefer not to, I certainly do some traditional joint replacement. Some insurance companies dictate whether or not they're candidates for robotic assisted. So there are some cases where I still do traditional joint replacement, but by and large, a majority of the joint replacements I do are all robotic knee and hip replacements.
Yeah. Is it a faster procedure, slower, about the same?
Yeah, that's a good question. A lot of surgeons are reluctant to make this change because of the concern that it's going to take significantly longer. But I've been doing these now for over 2.5 years, and a traditional knee replacement takes me maybe 5 minutes longer, or 5 minutes less than a robotic assisted procedure, but nothing significant when it comes to time of the operation.
Are there, you mentioned that there's people that can't do it because of pre-existing hardware or something like that. Are there other people that are like, well, maybe we better just do the traditional approach? I mean, like, what are like?
Yeah, I very rare that a patient is feels strongly that we shouldn't do the robotic approach and that we should do traditional. More often than not, it works the other way, where patients come in specifically requesting robotic assisted joint replacement.
Yeah, it would seem to me. So what would you say, do you have an idea of what percentage of knee and hip replacements are robotically assisted these days?
Yeah, I don't have a great number. I do know that over 500,000 joint replacements were done robotic assisted in the United States last year,
Hmm.
but I don't know what percentage. There are a lot of joint replacements that are done each year, so I really don't know what percent that plays out to be.
Uh, was this something you were taught in medical school, or is this something you learned afterwards?
This is something I've learned afterwards.
Yeah.
Initially, robotic assisted joint replacement was only available for partial knee replacements, and we actually started doing those over 10 years ago. But the technology to be able to do it for complete knee replacements and total hip replacement has only been out for the last 4 or 5 years. And so it's something that has required some additional training after medical school to be able to do so.
Yeah. And what made you gravitate to? Are you just into like the new cutting edge technology, if you will?
Yeah,
or-
I do like the new technology. I liked the procedure as it applied to partial knee replacement. And so it wasn't a big leap to extend that to full knee replacement. There is certainly a learning curve when it comes to something like this, and a comfort level to feel that you're able to trust the robot to do what it says it's going to do. But once you get through this and get experience at it, it really does make the surgery much more consistent and reliable.
So you say there's CAT scans for the robotics. Do you not typically do a CAT scan on a traditional knee replacement?
Correct. Traditional knee replacements are based on X-rays, and we can do some sizing and templating from a two-dimensional X-ray, but normally we don't do a CAT scan or an MRI prior to a traditional knee or hip replacement.
Is that I guess I need to understand what a CAT scan is. That kind of more of a three-dimensional view as opposed to an X-ray?
Yeah, well, an X-ray is a single static image that's two-dimensional. A CAT scan is a stack of X-rays, so to speak, where it's like a meat slicer that it's taking repetitive X-rays from front to back or side to side, so that you can the computers can actually digitize that and create a 3D image from multiple 2D images, if that makes sense.
Yeah. So what's next in the world of robotics and orthopedics? What are they talking about these days?
Yeah, I am a hip and knee surgeon, so I've talked a lot about how this applies to my practice, but robotics are moving towards shoulder replacement and even spine surgery now. And so it really is the application isn't going away. In fact, it's becoming more prevalent through multiple areas of orthopedics. A lot of robotic surgeries, they're talking about general surgery and prostate surgery and this Da Vinci robot that's been used for some other procedures. This is for orthopedics is relatively new, and we're really kind of figuring out, what it's going to apply to. But for now, it's hip and knee replacement, but move shortly spine and even shoulder replacement.
Wow. And the benefit is precision, right?
Correct. Yep.
Yeah.
Exactly.
What's this Da Vinci robot?
I'm not a general surgeon, and
Okay.
so, but the Da Vinci robot is a little bit different in that the surgeon is sitting at a table away from the patient and manipulating or using tools and devices that are actually being done on the patient in a different location. And so they're sitting down doing robotic surgery kind of virtually, and the robot is doing the surgery on the patient at the same time. I don't know if that's the best explanation, but that's the best I can do.
Well, that was a question I was going to head to is the future that you're in Cleveland and you're doing a surgery in China?
Yeah, I don't see that happening, at least not in my lifespan. However, the robotics applications are becoming more and more accurate and more consistent. And so we're able to do more and more procedures. But at the end of the day, the surgeon, in my opinion, needs to be there and needs to be able to make adjustments and call an audible when necessary. And so I think I don't see a time or a place when I'm not going to be actually in the operating room doing the actual operation.
Yeah. Um, what are some other cool technologies outside of robotics that you're into?
Yeah, that's been the biggest part because I'm a hip and knee surgeon. Uh, it has evolved over time. Initially, we used an MRI or a CAT scan and did 3D reconstruction, and then we were able to literally, as you said, make a model, an actual palpable model of the knee replacement, and then use that to determine our implants and our positions. But it's evolved now to doing it all in the virtual world. So we're able to make so many more adjustments on our computer and say, hey, if I went a little bit bigger, how would that affect the patient's knee flexion? Or hey, if I went and cut this in a little bit more of an angle, would that straighten out their leg? So we can correct some more and more severe deformities, and we can do it more on a trial and error basis on our computer, so that at the time of surgery, we are much more able to predict how that outcome is going to affect that patient.
Do you think you'll be using like augmented reality or virtual reality glasses in the
Yeah.
future?
I see places in training where surgeons in training and even orthopedic surgeons in training are doing that more and more. But I don't know that, again, I'm in my 25th year in practice. I don't see where that's going to happen in my career.
Uh-huh.
But gosh, I don't think I'm able to predict where we're going to be in another 20 years.
Yeah, right. That's the coolest thing about medicine is that it's driving so fast for innovation. And I
Yep,
mean,
it sure is. I feel like, there are certain things that come out, you always have to use some caution with the newest, latest, and greatest technique, and make sure that it is reliable and reproducible, and everything that you think it's going to be. But so when I first started with robotics, it was very limited on the cases that I did, and I was very selective. But now that it's become more standard of care and more accepted and more predictable and reliable, it's something that can apply to more and more patients.
and what about 3D printing? Do you imagine someday they'll print these parts?
Well, I don't know that it's going to be printed, the actual implants, but I know, for example, in some of our trauma colleagues who are orthopedic surgeons who fix complicated broken bones, they're able to take x-rays and CAT scans and 3D print the actual broken bone pieces, and then they can put them together on their desktop and determine how they're going to put them together at the time of surgery. You can even pre-contour the plates and determine where you want to put screws based on those 3D printed models. And so that's already happening in orthopedic surgery.
Wow. So you're printing people's bones so you can look at them in more detail.
Correct. And I hate when I start a sentence when I trained, but when I trained, we took an X-ray of complex broken bone. We laid a transparency over it and drew it out, and then we cut those pieces out like a puzzle, and then we would lay them out and piece them back together and figure out where we wanted to put the plate. But again, this was two-dimensional from a single X-ray. Now we can 3D print the actual bones and actually put them together before we get into surgery, and it's way more accurate than it used to be.
Do you find that in the medical profession they like to invest in this innovative technology, or is there a lot of like cost benefit analysis, or like,
Yeah.
no, we really need to do this? Like, what's the culture like as far as
Sure. It's an interesting question. So the vendors that make this technology always are trying to be the next best, greatest thing. And when they are the next best, greatest thing, they're quite expensive as until they become more routine. And so the hospitals, don't want to spend top dollar if they don't know it's going to show the benefit on the back end. And so there is definitely always a drive to be the next best, greatest thing by the vendors and the researchers. The hospitals tend to lag a little bit behind because they want to make sure that it really is worth the expense before investing in that.
yeah. I'm looking at your background. You're with university hospitals and in
It,
Cleveland, and Cleveland it seemed like it's always been an innovator in the medical space. So do you
Yep.
feel like there's a benefit being in Cleveland that you're getting to do this?
Sure. When you mentioned that, I would be remiss if I didn't mention that this robotic system is quite expensive and not a lot of hospitals have access to it. We are very fortunate where I work at Elyria Medical Center that they made that investment and we're able to offer this to our patients because not a lot of centers are willing to make that investment. And that's something that as you said, Cleveland area and UH in particular have been very supportive of that.
Yeah. I was talking to a doctor last week in an interview, and we were talking about people that wanted, young people that were interested in medicine. Do you ever have like interns or people that want to observe this come to watch you do these
Yeah,
procedures?
Our practice does support multiple medical students and residencies, and we've had them come through on rotations as well as physician assistants. I have assisted in some of the training for this robotic procedure. My partners have come and I've walked them through the procedure and helped to train them. I've also gone and given some lectures and instruction, teaching people how to do this robotic procedure. I've had other surgeons come in from other institutions to observe as well. So yes, it is cutting edge technology and there's a lot of interest in it and I'm happy to teach.
Is this like one of these things, like a CAD machine? So you're, in manufacturing, people are, they're creating parts and stuff, and you have to know how to be a CAD develop. You have to know how to program these things. Was that part of the training, is understanding how to program this robot?
Correct. And I think that's a interesting, something that I've thought a lot about is, you have to be, on the one hand, let's do it this other way. On the one hand, it makes it much easier at the time of surgery to do a robotic assisted total knee. But on the other hand, in my opinion, you need to be an experienced knee surgeon with traditional knee to know all the hiccups and potential pitfalls that there can be at the time of surgery so that you can get yourself out of that. You can't just lean on the robot to just get you through it because it's only going to be able to reproduce what you did in the computer. When something goes awry, you need to be prepared to fix that. And in surgery, anything can happen, you need an experienced surgeon to be able to deal with that.
Yeah. I would imagine when you first started, that was probably a little nerve-wracking, right? I mean,
yeah, it wasn't a black and white transition. There was a gray transition where I did part of it robotic and then brought out the traditional instruments to compare and make sure that it was doing what I thought it was doing. So there was certainly a transition where I was doubling up and doing a little bit of both to make sure that the results I was going to get were what I was expecting.
Yeah. Like when you buy that machine, does it come with a training guy? Like, is it a doctor that comes along with it and shows you like?
Yeah, it not so much in that way, but you're not permitted to use the machine until you've done the training. You can't just show up and use it. You need to be fully trained to be able to perform robotic assisted surgery.
Yeah. Yeah. Well, that's very interesting. Well, we've talked a lot about a lot of different topics. Have I missed something that you wanted to touch
No, I think
on?
that was the main thing I wanted to hit on. I think this is something that's unique at Elyria in particular, and it's something that we've really been very proactive with our joint replacement program, and I think we've had some great results with it.
Yeah. So it sounds to me like, I mean, if you have the opportunity to use the robotic assisted surgery, this is a great opportunity for you. I mean, 9 times out of 10, things are going to be fine with the regular, but if you're that one time, then you want the robot.
Yeah, I'd say 95 times out of 100.
Right, okay, sorry.
It's great, but
right. Yes.
But you're right. Your point is well taken. Yeah, if you can, even the smallest improvement, it's a major operation, and so anything we can do to make it better, I'm all for it.
Yeah. do you find that does it help recovery time? Do you seem to?
Yeah, I don't see it as much in the early recovery. As I said, it feels more natural because
Yeah.
it's individualized, the position that we're placing this implant in. And so there is that benefit. But there's the hospital stay, the pain medication. There have been a lot of studies comparing traditional and robotic assisted in it. It's all over the board. So I wouldn't say it's any worse, but I can't say it's markedly better either.
Yeah, right. Very good. So, if a person, when we talked last, one of the great things about our last conversation was you were like, you're not going to ruin your knee so bad that I can't fix it, which doctors never tell me that because I'm always putting off going to the doctor. But I love the fact that, like, this is a pain and mobility determination, which I learned from you. So, so this is something like, is this a conversation you bring up when you're investigating a knee or hip replacement? You're like, so, do you talk about, as the patient, do you bring up the robotic component of it?
Yeah, it is part of the conversation. We make sure that the patient understands there is the CAT scan that's not normally required with joint replacement. And that's part of the process of once the patient is determined to be a candidate for surgery and they've decided to go ahead and proceed forward. There are a sequence of steps that we go through to get the CAT scan. That we have a pre-op visit with the patient to counsel them on the robotics and what to expect at the time of surgery. We have a class that the patients go to where they also are informed of, all the steps of the recovery to be expected. The robotic side of things, the implants are the same, as I said earlier. And so there are robotic patients and traditional patients on the floor and recovering and rehabbing together at the same time. The restrictions and precautions are quite similar in all those patients.
Yeah. All right. Well, doctor, thank you so much for taking the time today.
No, I appreciate it. Thank you. I'm happy to do it.
So awesome. All right. Well, I look forward to talking to you again real soon.
Okay, man. Thank you. Have a great afternoon.
Okay. All right, everybody. Thanks so much. Thank you, doctor. And we'll see you next time.
All right. See you later.
Okay. Bye.